Let's take a look at our chest. And how important is this? Really important. So take a deep breath, stick with me, and I'm going to walk you through this. All right. Now, as we go through this, I would like for you to point on your own chest where we are. By looking at this, well, remember, a mirror image. So we have aorta. The aortic valve will be right, parasternal, second intercostal space. Are you pointing to it? That is where it is. Why? Do this for me. Here's your left ventricle. And you have an aortic arch, anatomy. So where's my aortic valve? Right, second intercostal space. What about the pulmonic valve? Second intercostal space, left parasternal. Where's your right ventricle? Down by the parasternal on the left side. And so therefore pulmonic valve will be here. Are we clear? That's normal. We're not doing any pathology right now. I want you to go in the fourth intercostal space now. We're still on the right side of the heart. The right side of the heart. Picture that. Conceptualize that for me. Good. And fourth intercostal space, left parasternal. That's your tricuspid, T. And then we have our mitral. All of these you talked about in anatomy, physio. Now we're going to put things together and put some pathologies to these. Your mitral is going to be where, please? Apex. Where's your apex located? In normal heart. Fifth intercostal space, mid-clavicular. Right about here. How many times have we talked about mid-axillary? A few times. That would be lateral displacement. Automatically gives you what? You're thinking about cardiomegaly for whatever reason. But fifth intercostal space, mid-clavicular is your mitral. All right, normal. Let's put in some pathologies. Let's begin with the systolic murmur here by the aortic side. With an aortic side, well, who's your patient? Oh, I'm just going to give you one little clue clinically for each one of these major murmurs, and then we'll get into these in greater detail as we get into valvular pathology. Okay, not to worry. Aortic stenosis. Hey, doc, 32-year-old and feeling tired at walking a few blocks. May or may not have chest pain. I've been walking my dog, and after a few blocks, doc, I feel tired, and I feel a little dizzy. Chest pain? Yeah. But then I stop and it goes away. Or the patient may not have chest pain, but definitely feels fatigued, maybe a little bit of dizziness. Okay. Next, upon cardiac auscultation, you hear a murmur, second intercostal space, right parasternal, and you hear the murmur radiating up into carotid. Diagnosis right off the back, aortic stenosis. Tell me about this patient. While walking, the dog felt tired. Maybe perhaps chest pain, maybe not. What was that all about? If you have aortic stenosis, tell me about stenosis. Rigid aortic valve. It doesn't want to open. So what happened to cardiac output? Decreased. When you have decreased cardiac output, how are you going to feel? Not too great. You might find a little tired, or maybe perhaps there might be angina. We'll talk about this. And tell me about that murmur. Where was it radiating to? Radiating up into the carotid. Not the blood. Your patient wasn't doing this. Yes, sir. Yes, sir. Yes, sir. The patient wasn't doing that. That's aortic regurg. We'll come to that later, okay? Right now, the aortic stenosis. Don't worry. All I'm doing is introduction. You expect to hear that where? Right, second intercostal. What about some of these others? Aortic valve sclerosis as a differential and a flow murmur with the increased amount of blood passing through there. Let's move on to another one. Another area here would be your pulmonic area. Where am I? Second intercostal, left parasternal. Here you might be thinking about pulmonic stenosis. Differential? Oh, maybe it was something like tetralogy of Fallot, pulmonic stenosis. Or maybe it was an infection. Really? What kind? Tell me a virus that may result in pulmonic stenosis. You're telling me rubella. Rubella. Let's continue. And then we have in the tricuspid area, we're going to divide this as such, and you want to do the same, please, so that you keep your thoughts organized. Systolic and diastolic. I'm going to walk through the easy ones first. Let's do systolic first. First, where am I? Fifth intercostal and left parasternal. Stick with me. A lot of information. This will be repetitious, and I'll keep reinforcing it, but it begins with understanding where you are. As integrate. That's the name of the game. So here, let's begin with tricuspid regurg. How did that occur? Oh, maybe it was due to an IV drug abuser. Maybe there was issues with the carcinoid. Okay? Anyhow, you're on the right side of the heart, left parasternal, fifth intercostal. And it's a systolic murmur. What does that mean to you? That means that the tricuspid valve doesn't want to close. Which way does it normally close? The tricuspid valve, here's my right ventricle, and here's my tricuspid valve, and here's my right atrium, right? And the valve is supposed to close this way. But it doesn't close properly, and it just opens up during systole. What what does that mean to you in terms of your murmur? Between S1 and S2, you're going to hear a holosystolic murmur. We'll be spending time with that, not to worry. But where am I? Left parasternal, fifth intercostal. VSD, a very, very common, right? Very common. One of the most common congenital heart diseases is ventricular septal defect, and that'll be a systolic murmur. What kind of shunt is this, please? It's a left to right shunt. But Dr. Raj, why did you say in tetralogy Fallot that it was a right to left shunt when that patient had a ventricular septal defect? In tetralogy Fallot, do you not have a VSD? Yes, you do. But why is that a right to left shunt? And here you're telling me it's left to right. Because in tetralogy Fallot, you had, number one, pulmonic stenosis, resulted in right ventricular hypertrophy. You did have a VSD, and the blood was rushing from the right ventricle into left ventricle. So there it was a right to left shunt. Here, it's a left to right shunt, period. This is not tetralogy. I'm just strictly saying a VSD. Well, with diastolic murmur, a tricuspid stenosis. Say here once again, it was IVDA, meaning to say intravenous drug abuser, Staph aureus. I am injecting, along with my drug, staph. There it goes into my vein. Ha, 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 ha. Fantastic. And my staph ends up on my tricuspid valve. What is it going to do? It causes complete stenosis. When is it supposed to open, your tricuspid valve? During diastole. But it's not. So therefore, if you hear a diastolic murmur after S2, and you're at the fifth intercostal space, left parasternal, welcome to tricuspid stenosis. Okay, now let's integrate atrial septal defect. We're going to have fun here. Ready? Atrial septal defect. What heart sign are you paying attention to? S2. With S2, what kind of split is this? A physiologic split, a widened split, or a fixed split? You tell me. Fixed split. Blood was always rushing from the left atrium into right atrium, and therefore S2, A2, P2 was always fixed between your inspiration and expiration. It didn't change. But that's a fixed split. How can you then bring this into a diastolic murmur? Listen. So now the blood is rushing into where? Into the right atrium. Okay, fantastic. When is a tricuspid valve supposed to open? When is a tricuspid valve supposed to open? During systole or diastole? Diastole. What's the definition of a murmur? Increased turbulence across a valve. With all this blood in the right atrium and passing across a tricuspid valve, are you not increasing your turbulence? Of course you are. Could you result in a diastolic murmur at the fifth intercostal space, left parasternal? Are you pointing to it? Please do it now. That's an atrial septal defect. Now, clinically, you can go one step further and mean to say that eventually you might find issues up by the pulmonic area as well. That must be understood, but go step by step. Build upon the foundation so that you never crumble. If your foundation is never strong, like a building, then what's going to happen? You have a tornado, what have you, and then, boom, the building is gone because the foundation was weak. Your foundation is strong. No matter what they throw at you, the attending, licensing board, you're guaranteed to get that question right because your foundation is solid. And that's what we're trying to build here together. Let's continue. And finally, we have our mitral area. Where are you? Fifth intercostal space, and you're at the midclavicular. Okay? Pretty straightforward. Both of these will be your mitral valvular issues, and we'll get into greater detail. You all know about mitral regurg. Take your time. The mitral valve is supposed to close from the left ventricle towards the left atrium, and if it doesn't close properly, you have a holosystolic murmur between S1 and S2, don't you? And where would you hear this? By the fifth intercostal space and by the midclavicular. Or mitral stenosis. If you have mitral stenosis, let's say it's chronic rheumatic heart disease. Chronic rheumatic heart disease may result in mitral stenosis. The mitral valve doesn't want to open. You have an opening snap. It's a mid-diastolic murmur. And then you have this particular murmur taking place at the same location. Fifth intercostal space, midclavicular. I sound like a broken record, but it's okay. I keep saying this over and over again, so my voice haunts you whenever you might be posed with a question. And then finally you have PDA. Look where you are. Patent ductus arteriosus. What happened here? The ductus arteriosus didn't close. And so therefore, close your eyes. Tell me about this ductus arteriosus. What are you connecting? You're connecting the aorta to the pulmonary artery. You with me? The aorta with the pulmonary artery is what you're connecting. And upon birth, you have the ductus arteriosus still open. And then where's this blood going? The blood's going from the aorta into the pulmonary artery because you should know the systemic pressure is quite high when compared to pulmonic. And so therefore, what kind of murmur are you going to have? What did I just do? That's a machine murmur. At no point with my particular rendition, let's make an album called Dr. Rogers' Valvular Heart Sounds. At no point in my rendition of your PDA could you differentiate between S1 and S2. Could you? You couldn't. Welcome to PDA. We'll be spending time, not to worry, with the pathophys of every single one of these valvular heart diseases. And a question that you might get would be one in which you go on, and there's a computer, you have to put on headphones, you listen to the heart sounds, and they'll ask you, and they'll put a chest on your screen, A, B, C, D, E, so forth, and they'll ask you, well, where exactly on this chest would you expect to hear this particular valvular heart sound? Last few points here with our location of a couple of important valvular heart diseases, and it could be a little tricky if you're not paying attention, so I really want you to look at me and pay attention to what I'm saying. So, first and foremost, we're on the left parasternal, approximately at the third intercostal space. That would be the best location. Let's talk about the first one. This patient here is the one that would be perhaps presenting with, yes sir, head bobbing. Oh, I feel my radial pulse, and it's, wow, I can really feel it. It's bounding. Boom, it's hitting me in the face. It's a bounding pulses. Aortic regurg is what we're referring to. Now, if there is aortic regurg, give me some differentials of aortic regurg. Maybe congestive heart failure. Aortic root is becoming dilated. Maybe this patient has ankylosing spondylitis. Look at me. Well, I'm pretty stiff as is, but when I bend over, my back and my vertebrae has a proper curvature. Okay, but if I was half my age and I was 20, I just gave away my age, but whatever. So if I was 20 and I was bending over and I didn't have a proper curvature of my vertebrae, what is my diagnosis most likely? Ankylosing spondylitis. Why am I bringing this up? Because with ankylosing spondylitis, what might be its associated valvular heart disease? Aortic regurg. Do not forget that, please, ever. My point is this. Now, I want you to think about that anatomy again of the aorta. So we have left ventricle, aorta. If you have regurg, then blood is rushing back from the aorta back into the left ventricle. Is it not? Of course it is. And this is occurring when? During diastole, isn't it? Because during diastole is when that aortic valve should close. Don't worry. We'll go through all this again, but I'm just putting all this together for you because this is how good you need to be. So now you have after S2, early diastolic murmur, moving towards the apex, so therefore aortic regurg would be expected to be heard best at the third intercostal space, left parasternal. So what kind of question might you get? Well, you walk in and you have your headphones and they give you a chest on your screen, and the chest on the screen will have A, B, C, D, E. And then you'll have to listen to the heart sound, and then you would have to locate where exactly on the chest you would hear aortic regurg, and this is where it would be, a diastolic. Now, if it was pulmonic regurg, pretty straightforward. Pulmonic regurg, you're at the second intercostal space, left parasternal, and you're going to regurg back into right ventricle. And so that you would expect to hear it around here as well. Third intercostal space, left parasternal. Then we have this patient. If this was a young patient, not obese, no rheumatic heart disease, no bicuspid aortic valve, none of those issues, but was an athlete, Maybe a volleyball player, maybe a tennis player. And when they were going for their volley, either for the ball, well, they fall. And when they fall, they never get back again. They never get back up. Sudden death. That's sad. This then brings us to an unfortunate pathology called hypertrophic obstructive cardiomyopathy. What does that mean? What's obstructed? The outflow tract of what? Close your eyes. What's obstructed is the outflow tract from the left ventricle towards the aorta. Are you with me? So therefore, where would you expect to hear this murmur, this systolic murmur, when the blood is trying to be ejected? Once again, third intercostal space, approximately left parasternal. I hope that's clear.